Today we have our Chief Medical Officer, Dr. Michael Green, and Dr. Kathleen Brown, and they're going to be answering any and all of your questions. So go ahead on the right-hand side, you can start putting your questions in the chat, and I'm going to have Dr. Green and Dr. Brown introduce themselves. So Dr. Brown, do you want to start?
Sure. I'm Dr. Kat Brown. I'm the Winona doc in Pennsylvania. So any of you calling in from Pennsylvania, hello, this is me. And I just wanted to start off just by reminding everyone that October is Breast Cancer Awareness Month. I don't know if everyone's aware of that. You've probably seen some things in the media, but this is my plug as a gynecologist to just let you know that breast health is very important. And if you haven't had a mammogram recently, then you should go ahead and schedule one because it's Breast Cancer Awareness Month and we want to reduce your risk of breast cancer. So.
Great. So hi, my name's Mike Green. If you've been on a Q&A before, you've seen me before. So I'm the Chief Medical Officer of Winona. I'm also one of the prescribing physicians. So hi to all my patients and get your mammograms too. And I just want to assure you that we don't discriminate by colors. So we do have a green and a brown, but we have other doctors that don't have color names. So when Dr. Brown came on, I was teased, what, are you only going to hire color doctors? But anyway, so that's how it worked out. But I always like to start off just with a little tidbit, if for no other reason, gives you a chance to type your questions in. And this gets like really uncomfortable if you don't type questions in, because then we kind of just stare at each other. So please give us your questions. That's really what this is all about. But one of the things that we do every year as OB-GYNs is we recertify for our boards. We're all board certified. And I think the OB-GYN board recertification process is actually a really smart and good process. And so what they do is they pick out sort of the articles over the last year that they think are important that we should read. And they have this list of articles and we have to pick a certain amount and read them. And then it's a little open book test to prove that we read them, which I think is a good way to do it. It's sort of, here's articles you should be keeping up on, which we should, and please read them and sort of prove you read them. So that's what we do. So one of the articles, they had one menopause article this year, but obviously the OB-GYN boards thought it was important enough to include, and it really was an article from the cardiology folks talking about the cardiovascular benefits of hormone replacement therapy. And as you know, we say all along, and this is an article that sort of I already knew about, but important article, talked about timing of HRT, and that starting HRT earlier gives you more of the cardiovascular benefit. And that's sort of the whole idea we've talked about, why we don't want to start it for the first time over 60. And so really, I get this question a lot. It's like, well, I'm still getting periods. Is it too early to start HRT? No, if you're having symptoms, let's get your symptoms under control, number one. And number two, it gives you other health benefits, including cardiovascular benefits. So that was one of the things the article talked about. The other thing, there was a little tidbit in the article, which I found interesting. And that is that 10% of women complete menopause by the age of 45, which to me was sort of a bigger number than I really thought. That's a pretty decent percentage for that young. And remember that the perimenopause symptoms tend to last 10 to 15 years before full menopause hits. And so, there's a lot of younger women that are having symptoms of perimenopause that, most people sort of in medicine, might sort of blow off. Oh, you're too young to have this. And actually you're not. At least 10% of women are done with menopause by 45, which means they're having symptoms in their late 30s. And so if you're, in that age group and you're having symptoms, no, it's not necessarily too young to be going through that. So that's sort of my little monologue for the day. So why don't we, I think we've got some questions up.
Okay, we already have a lot of questions, so
Marvelous.
Off to a good start. The first question is from Tara. What should I tell my PCP about the hormone medicines I'm on from Winona?
Well, I would say don't be afraid to discuss exactly what you're taking with your provider. And if you can't really describe to them what dose you're taking, don't ever be afraid to bring your medicine with you to show your primary care doctor. I guess the question would be if you ever talk to your doctor about hormone therapy, if they were reluctant to really discuss it with you or prescribe it for you, and if they weren't comfortable, then you could discuss, how long you've been taking our medication, how you're feeling with it. But it's important to reveal all the medications you're taking to your physician when they're taking care of you, so that they have a complete picture of everything in your medical history and your health.
I would also say the opposite is true too. Please share with us if you get started on a new medication or you get a new health diagnosis, because it can be important for us to know to help prescribe appropriately.
Okay, the next question is from Sherry Jackson. I had a complete hysterectomy 13 years ago. I never took any hormone therapy. The quiz recommended I take estradiol. Do I need this?
Well, so based on your symptoms is why we recommend certain medications. And the other thing I wanted to just bring up, so some patients will say complete hysterectomy or partial hysterectomy. And as an OB-GYN doc, those terms aren't really something we use. So a hysterectomy by definition means you've had your uterus removed. A uterus doesn't make or do anything with your hormones. It's purely the vessel for a pregnancy to grow in and for your menstrual tissue. So if you had just your uterus removed, that means you still had your ovary, you still have your ovaries. So that it's not unusual for 13 years to go by. And then with time, as we age, our ovaries stop producing as much estrogen. And so if you're starting to have hot flashes, you're having night sweats, you're having symptoms of menopause that are bothersome to your quality of life, then absolutely the estradiol will help with those symptoms.
Next question is from Lisa. Is there any increased risk for breast cancer if I have dense breasts and I'm taking HRT?
Well, so studies have shown that women with dense breasts can be at higher risk for breast cancer. And one of the reasons why I think that is that because with dense breasts, it's very hard to image the breast. With dense breast tissue, the mammograms don't have the normal penetrance. Like we don't see the tissue as clearly as someone who doesn't have dense breasts. So sometimes an early cancer can go undetected in someone who has dense breasts. So, and I guess we can talk about the risk of breast cancer with HRT in general. So, with the studies and looking at HRT and looking at women who were started at HRT in different ages, we think about whether they were given estrogen alone versus estrogen and progesterone. And so we take all those risks into account when we're prescribing for you. But, having the dense breast does increase your risk slightly. I don't know if you want to add to that, Dr. Green.
So yeah, there are some advanced imaging techniques that can overcome this. And so if the radiologist says they're having a hard time reading your mammogram because of dense breasts, you can talk to your doctor about other imaging modalities, ultrasound, MRI. There are new technologies that can help so they can see things a little bit better and might mitigate that risk. And yeah, I agree with you, Dr. Brown. I don't think it's actually an increased risk of breast cancer. I think it's an increased risk of undetected breast cancer. So it doesn't necessarily mean that you're more likely to get breast cancer. It's just that they may not find it as early because it's harder to see. It's basically what you explained. But yeah, I think, and then so if you look at the whole cancer risk with HRT is really a little more nuanced. People tend to look at breast cancer because that's the scary thing for women, because it's such a common cancer. And the studies show with combined hormone replacement therapy, estrogen and progesterone, there is a slight increased risk of breast cancer. Although those studies also show that with estrogen alone, that increased risk doesn't exist. However, HRT decreases risk of other cancers, and as I mentioned earlier, decreases your cardiovascular risk. So if you look at life expectancy, women that are appropriate candidates for hormone replacement therapy that are started before they're 60 have a longer life expectancy than women that were never on hormone replacement therapy, mostly because of the decreased cardiovascular risks. There's kind of a joke, you got to die of something eventually. It's like, if you say there's one statement that you can get like the whole world to agree on, that is that everyone has to die at least once. So there's, very few people would disagree with that. Of course, nobody wants breast cancer, but the idea is that if we can live longer and we can live healthier with this and have an improved quality of life, that's really the goal. And to cherry pick out one thing, even though breast cancer is a scary thing, when you look at the big picture, you're actually more likely to live longer and healthier on hormone replacement therapy than off of So that's kind of the perspective that I look at it with.
The next question is from Danielle. Do you prescribe topical HRT as well as vaginal estrogen?
Yes, we do. We have topical HRT in the form of patches and also body cream. And we also have vaginal estrogen cream as well.
And let me add that for some women, they need both, and it's safe to be on both.
Right.
The body cream and the patches do help with vaginal symptoms, but sometimes the vaginal cream can help more, but the vaginal cream doesn't help as much with other symptoms. So there are situations where some women end up being on both.
Yeah, I have some patient on both as well.
Yeah.
The next question is, if my TPO is 912 dose, that mean I have an autoimmune disorder? Does that mean I have an autoimmune disorder?
I'm not quite sure what TPO means. I don't know if she's referring to a thyroid oxidase antibody or something. I'm not quite sure, but we're talking about menopausal hormone therapy and not really thyroid disorders or immune disorders. So I'm not quite sure this is the right forum for that.
Yeah, I don't know if you caught that little smirk where we were both like, "You gonna take this? You gonna take this?" So
If you could clarify.
We're gynecologists and we're experts in menopause treatment. We're not. Well, I'm not.
I'm not. Women's
I'm
health.
not an expert in autoimmune disorders, honestly. And so, you don't want to ask your plumber advice about how to fix the roof. So that would be a really important question to talk to your family doctor about.
Right. Whoever ordered that test for you is the person that you should go back to and ask about the results specifically.
The next question is it normal to start to bleed when you start the medication? I hadn't had my menstrual cycle for about 1.5 years, and now I'm back to having bloody discharge.
So sometimes when you first start HRT, it can be normal to have some spotting because the hormone is affecting that uterine lining slightly. And especially for women who start to have menopause symptoms or maybe have gone a year without a period, but they're less than the age of 50. Some experts would argue that you're really not fully menopausal until you've gone 2 years without a cycle. So sometimes the medication can kind of activate that endometrium, that lining of the uterus, so that you can have some spotting when you're first adjusting. And usually if it's just due to your body acclimating to the medication and getting used to the HRT, it should resolve with time as you continue your therapy. If it doesn't, if it continues beyond that time, then we usually recommend getting it checked out.
Tracy is asking, any way to mitigate any of the early side effects on HRT and DHEA, such as bloating, water retention?
So for bloating and water retention, I usually tell patients to really watch their salt intake. When you're starting new medication and you're making changes in your health, really focusing on optimizing your sleep, really optimizing your diet, eating healthy, drinking plenty of water, and also watching that sodium intake can help with that as well. And sometimes it's just an adjustment period. Your body is learning how to adjust these medications throughout all the tissues in your body, not just to affect those menopausal side effects. So, generally these symptoms resolve with time, but if you do your part in trying to take care of yourself as you're getting used to those medications in the beginning, that should help. Occasionally I have patients who the bloating and the water retention is just a little bit more severe and more bothersome to them. So sometimes we might have them take like an over-the-counter water pill to help, to reduce the bloating and water retention.
Very rarely, I see patients that just seem to be extremely sensitive to these hormone changes. And so occasionally I will recommend, backing off if someone's really miserable and doing a slower start and maybe starting with one pump of the cream a day for the first couple of weeks, and then going up to 2 pumps, just to make the transition more easy, more gentle. The downside of that is it takes longer to get results that way. And we all want results as soon as we can get them. But occasionally for patients, that is a trick that I employ if they're really kind of having a miserable time of it. But if you can kind of hang in there and do all the things Dr. Brown said and let time, be on your side, this should eventually go away.
The next question is from Shannon. How do I know if this is the right medicine for me?
Well, really, if you take our quiz when you're doing your onboarding, and if you have significant menopause symptoms, if you're suffering from hot flashes and night sweats, if you're suffering from vaginal dryness, the brain fog, there's a whole list of symptoms. And if those symptoms are bothersome to your quality of life, and it's hard to kind of live your life and do your daily tasks without being bothered by these, then maybe HRT is right for you. You're the only one as a patient who really knows if that answer. We're here to help you kind of navigate through it. But you have to really look at the quality of your life and each day, if you're suffering from those symptoms.
Yeah, the easy way to look at it is here's how you know if it's right for me. If you take it and you feel better, it's the right thing. So, do you feel better on it or off of it? And you have to give it you have to give it some time, because it does take time to work. But that's really the ultimate test to know, what's the right dose. The right dose is a dose that takes care of your symptoms without giving you side effects. And once we find that sweet spot, then we know that's the right thing for you.
The next question is from Colleen. How long do you recommend staying on HRT?
Well, we generally say most women stay on HRT maybe 5 years, maybe 10 years, but average, I'd say about 5 years. And after that time period, we can try taking you off of HRT and kind of weaning you off to see how you do. Each woman, it's a unique situation. So, generally as gynecologists, we say we want you to take the medication for as long as you need to help your bothersome symptoms. And really it's up to you when you decide that you want to try to go off the medication.
The next question is from Linda. I'm taking the DHEA at night, but the first 2 nights I had a hard time falling asleep. Now I'm feeling more awake in the evening, not a bad thing, but wondering if DHEA is best taken in the morning. I'm taking the cream in the evenings.
Well, so it's really up to you when you take the medications and what fits into your daily lifestyle the best. But I do find that some patients can get a very energizing effect from taking some hormones, and sometimes DHEA can be that. When we look at when our body naturally releases DHEA from the adrenal glands, then typically that's in the morning. So for some patients that have this, difficulty falling asleep, or they're more alert in the evening after taking their DHEA, I usually recommend they switch to the morning and just see how their body responds. And sometimes that works better for patients. So maybe you should switch to the morning, Linda, and see if you feel better that way.
Yeah, I always give everyone permission. It's okay to experiment around this way. You're not going to hurt yourself by trying different times of day for both the DHEA, the cream, or the pills, or whichever you're taking, and see, because everybody's unique, and see how it affects your particular body and your situation. You're not going to hurt yourself by doing that. So it's okay to try different things and see what works best for you.
The next question is, hello, my name is Maggie from Las Vegas. I have been in menopause for over 6 years now. My question is, I prefer to use the cream. My previous doctor recommended estrogen and progesterone. I would like to know, how can I order your cream online?
So basically you'll go to the Winona website and you'll click to start your treatment, to start your care. It'll ask you your medical history. We want you to give us all the information that we need to best take care of you. And you'll fill out a questionnaire, a symptom questionnaire, and then you'll be linked to a doctor in your state, if we are in your state.
And that's me.
Yeah. Oh, because Vegas. Oh yeah, I forgot that she said she's from Vegas.
Yeah.
So yeah, it's as easy as that. So once you complete that onboarding process and you fill out that questionnaire for us, that links you in with the doctor, and so that way you can begin your treatment. Easy as that. No doctor's visit. You don't have to drive there. You don't have to pay your copay.
And it really takes about 5 minutes to go through the onboarding. So we try to design this for us to get all the information we need and nothing we don't need, to try to make it as easy for you as possible.
Samantha says, hello from California. Dr. Green's there too. I'm perimenopausal and 52 years old. I'm 3 weeks off of birth control. What can I take to transition into menopause? And is there HRT that I can take now?
Yeah, generally the hormones in birth control are typically much higher doses than what we use for HRT. So if you're already having symptoms and you've just stopped your birth control, we could transition you to a medication, whether it's really up to what form of medication you're most interested in. If you think the body cream would fit your schedule better, or if you want to take pills, or if you wanted to use the patch. But you could start that now. And actually going from birth control right into HRT will kind of ease that transition so that you're not suffering from the symptoms of menopause as brutally as some of your peers.
The next question is from Beth. Hi, I just started my hormones 1 month ago and I am spotting as of 3 days ago. I have been in menopause for 8 years. I'm 58.
So just like we mentioned earlier, sometimes when you first start the treatment, it can be normal to have some spotting and some light bleeding when you first start your HRT. So don't be alarmed, just monitor that. I usually encourage patients to kind of keep a log of when they see bleeding and really monitor how much bleeding they're seeing. And really we would expect that to resolve on its own within a couple months of starting therapy.
Reference about the benefits of this medication when telling my doctor I'm using bioidentical hormones if she's not on board.
Sorry, I missed the beginning of that.
She's asking if there's any articles or information that she can reference when she's telling her doctor about bioidentical HRT since she's not on board.
Since her doctor's not on board. Like several of our colleagues, right?
Yeah, so unfortunately, you're not going to win that one, in my opinion. So I've been out long enough to see this pendulum swinging back and forth. When I got out of residency in '99, we were giving estrogen, we were giving hormones to everybody. I mean, we were starting 80-year-old ladies on hormone replacement therapy, and it was, at the time, we thought it was the right thing to do. In hindsight, it turned out to be inappropriate. And the Women's Health Initiative study came out, and it grabbed big headlines. And unfortunately, when medical studies grab newspaper headlines, the newspaper headlines tend to be very sensational and don't really necessarily accurately describe what the study says. What it really said was, HRT is actually pretty safe and very useful, but you shouldn't be giving it to an 80-year-old lady out of nowhere. And so, there's we need to dial it back and do this right. Of course, the headlines were, doctors are trying to kill you with HRT. And so everybody sort of panicked, patients and doctors alike. And basically everyone stopped writing hormone replacement therapy. And so people that went through residency after that and up until sort of recently didn't get any education on hormone replacement therapy at all. Or the education was, this stuff's dangerous, you're never going to write it. Don't waste your time learning about it. And it's only recently where people have the pendulum's kind of swung back and people are like, hey, there's a whole lot of new data now that says, you've looked at this wrong. And actually, when you screen correctly and you use it appropriately, it's a very safe thing to use and can be extremely helpful for people. But these doctors that kind of came through residency during sort of dark times, they believe that this stuff is evil and terrible and you should never use it. And it's really hard, unfortunately, to turn that around. And I understand what you're saying, but most doctors aren't going to respond well to a patient handing them a bunch of articles telling them they're wrong. On the other hand, one of my first patients when we launched Winona was a lady that had Kaiser insurance, or Kaiser doctor. I don't write hormone replacement therapy. I don't believe in it. And so I got her on patch. She did great, super happy. And then she sent me a message saying, I'm so grateful for you and Winona and what you've done. But my Kaiser doctor has seen how well this works and has changed their mind and is writing me, and I'm getting it free through Kaiser. Like, hey, that's great. So, that is sort of how to evangelize, really, is look, this stuff's working and it's not killing me and it's safe. And that's the way that your doctor's going to learn that this stuff, isn't really as terrible. I think that's sort of the right approach. Of course, you want to share with your doctor what you're on so they know, in case they're writing other medications. But just friendly advice. I don't think what you're thinking about is going to go over well for most people. Unfortunately, we tend to be pretty stubborn. as doctors.
The next question is from Melissa. When should I be thinking about transitioning from birth control to HRT? What are the different types of HRT?
So for most women that are on birth control, we usually will keep women on birth control if they're using it for cycle regulation or contraception until about the age of 50. And at 50, at that point, especially if you're a non-smoker, but at 50, we say, it's probably time, we could probably stop this. Your chance of getting a spontaneous pregnancy and becoming pregnant are very low. And at that point, we could transition over to HRT instead of the birth control, because the birth control had likely been helping your symptoms, perimenopausal symptoms. So the different types of HRT, we at Winona, we specifically have tablet or pill form. We also have patch form, and we also have body cream. And then we also, for vaginal dryness, we have the estrogen vaginal cream as well.
The other thing I would like to add is that birth control pills have a different type of hormone than bioidentical HRT, and they're in a much different test. And it's interesting. It's been one of the things I've really learned, and some of it's trial and error, is that there are a lot of women on birth control pills that aren't getting symptom relief of their menopause symptoms. And adding bioidentical hormones sometimes helps fill in that gap. I'm not opposed to having somebody on both. So if you're on birth control pills because you need the contraception or you need the cycle control, but you're still having menopause symptoms, it's not unreasonable to try adding HRT to that. It won't make your birth control less effective. And the bioidentical hormones may act on the receptors differently than the synthetic hormones in the birth control pills, and fill in that gap and cover some of those symptoms that the birth control pills aren't hitting. So that's not an unreasonable way to go either.
Erin is asking, I've noticed my periods are longer in duration and heavier. When should I expect for them to regulate?
Well, so I guess without really knowing more of your history, like your age, if you were having regular cycles before starting your HRT, we need to know a little bit more specific. But generally, if you have any menstrual changes related to starting HRT, it's usually that first 2 to 3 months, and then after that, it usually improves. Looks like she puts a lot more detail in how many months that she's been on it. So July, August, September. Sorry, that's my guinea pig. That is not me squeaking like that.
Yeah, she said I got a period 2 weeks afterwards, July. So she started on June 30th, and then she got a period 2 weeks afterwards in July, then another 5 weeks later in August, then 3 weeks after, and now 2 weeks.
Guinea pigs and children popping in. Well, so it could be that the dosage may not be right for you. It could be that your body, in your menstrual cycle is responding to the hormones differently. But what I would do is I would really discuss this with your doctor, since they have your specific medical history and all your other medications, your age, everything into the picture, so that they can give you a better guidance as to what to do and what to adjust. We might need to dial either up or down on your progesterone versus your estrogen, but without knowing that background details, it would be hard for Dr. Green and I to recommend any changes to your medication dosage.
So the next questions come from Chris. The first one is, how does Winona calculate the correct balance of estrogen, progesterone, testosterone, and other potential hormones, given everyone has different balances?
So let me grab that one, since I designed the algorithm. That was one of the challenges. It's not just a challenge of Winona, that's a challenge in practice as well. So basically, the way we do hormone replacement therapy is we look at your symptoms, we look at your medical history, we look at sort of all these aspects, and then quite honestly, we take our best guess. And we say, gee, with this sort of combination of things, this is what typically works. And that really comes from experience. We have kind of a starting idea, but the more we do this and the longer we do this, the better we get at it. So based on my experience, I built an algorithm that sort of takes all that into account and comes up with a recommendation based on all these different individual things that you put in to the onboarding. I specifically sort of designed this to take the dose and like round down so that if anything, I'm going to give you a little bit less rather than a little bit more. And the reason is I'd rather you come back after some time and say, gee, it doesn't seem to be completely resolving my symptoms, than say, gosh, I'm having these horrible side effects. First, do no harm. And so I try to get the right dose, but if I err, I'm always going to try to err on the side of less rather than more. And so I built this algorithm, and then I started watching how it worked and really collected about the first 1,000 patients and changed it and manipulated it until I got it really good, and it seemed like it was as good as it was going to be. And it seems to work pretty well for the most part. People tend to be happy, and I find that if there's an issue, most of the time I find that I'm adjusting by increasing the strength of the medicine rather than decreasing the strength of the medicine, which is exactly what I was aiming for. So that's sort of how the algorithm works, and that's how we do it. In the office, we do the same thing, but we do it, we take your history, we do physical, and then our brain develops. We have this algorithm in our brain that we don't even know what's happening, and we choose a dose for you. So it's really kind of the same way, except honestly, I was a little bit more scientific about it. I started with that and then reevaluated over the first 1,000 patients or so to make sure that I was getting the dosage right and the type right and all that. And I think we've got it dialed in pretty well. But honestly, I continue to look at it, and we continue to tweak things a little bit to really fine tune this. We have, I forget where we're at, 11, 12,000 patients now that we've seen through Winona. So we have a pretty big patient population to work with and to evaluate. And I think we've got this dialed in pretty well, but that's how it works.
Chris has a follow-up question on that one is, if the person has not had a hormone level test in over 10 years prior to menopause onset, how are you calculating the balance of estrogen, progesterone, testosterone, and the other hormones?
Well, we really calculate your dose based on your symptoms. So, really checking your hormone levels is not very accurate because they can change. If you've had breakfast before your blood was drawn, or if you were fasting, if you draw the labs in the morning versus the evening, and just from day to day, they can change. So there's really no reason to dose your HRT based on hormone levels. It's really best to dose it based on your symptoms. So really, we don't recommend getting hormone levels.
Yeah, they're really not helpful. I shared this, I think, in a previous Q&A, but it's kind of like, for me, I'm on blood pressure medicine. They don't change my blood pressure medicine based on the levels of my blood pressure. They don't check a hydrochlorothiazide level. What's the level of the drug that we're giving you? They check my blood pressure, and your blood pressure's high. We need to add a little bit more medicine, or your blood pressure's perfect. Okay, we're good where we are. And it's really the same way with HRT. We don't check levels of stuff. We check your symptoms and adjust based on that. Sometimes it's hard for patients to wrap their brain around. I think there's this big industry out there right now selling drug tests, and there's a lot of money to be made doing.
Right. Be wary of anybody that wants to do salivary hormone testing and charge you $200 for that, or hair hormone testing was another thing a patient asked me about. There's really no scientific backing to any of that, and so it's all kind of a little bit of voodoo, and they're getting your money for no reason.
We try to do this, really. We try to do it as affordable as possible, and we try to keep it simple. Because for the most part, people respond to sort of a basic, simple regimen. And it doesn't need to be super complex. It doesn't need to be super expensive. We don't need to do a bunch of extra tests and stuff like that. Really keep it simple and listen to your body and do it. And that's the right way to do it.
The last question from Chris, and you guys kind of answered this one before, but is if a person's current OB-GYN is against any hormone therapy, including bioidentical hormones, can you provide the other points of view that bioidentical hormones are not a risk? Asking for someone with breast cancer on maternal grandmother's side, but not mother.
Yeah, I think that goes back to what Dr. Green was saying earlier, is that, you're unlikely to change your physician's mind, but I think it's important, you and your physician can agree to disagree, and just make sure that you're letting them know, and that you're putting that on your forms and letting them know what you are taking so that they're aware of it. But I don't think you're going to change their mind about whether or not they believe it's safe or not.
If your doctor says they don't believe it's safe, just blanket statement, I'm not worried about that. If they say, I have a lot of patients on hormone replacement therapy, but for you specifically, I don't think it's safe, I would ask them specifically why, and please let us know, because they may be right. So there's a big difference between, HRT is unsafe for everyone, and for your specific instance, I'm worried about this. In that case, there may be a reason that we would like to know about, obviously. The other thing is that family history of breast cancer is not a problem with hormone replacement therapy. And honestly, when we first started this was something that I kind of knew, but I wasn't that aware of it. And I really delved into the literature, and there's some really good big studies that show that it's safe to be on hormone replacement therapy, even with a close family history of breast cancer. The caveat is, if you have tested positive for one of the genetic markers for breast cancer, then it may not be a good idea for you. But if you have a family history of breast cancer, that in and of itself is not necessarily a reason not to be on hormone replacement therapy.
Shannon asked, I have irregular periods. My doctor did blood work and he stated I was nowhere near menopause. However, I have all the symptoms.
So this is another perfect example about how checking hormone levels is not a good indicator of what to treat you with, but also not a good indicator to tell you whether or not you're in menopause. So really, we look at your symptom profile, and we look at what you're experiencing as far as those perimenopausal or menopausal symptoms, those vasomotor symptoms that we talk about, like the hot flashes, night sweats. And there's some scales and questionnaires that if you Google menopause symptoms, you could find different symptom scales. But our questionnaire asking about those symptoms will let you know whether or not you would benefit from hormone therapy. So the blood work is not black and white. I'll say that way. But there are a lot of doctors out there that will run an FSH level, follicle stimulating hormone. They'll run estrogen level, and if your FSH isn't sky high, they'll say, well, you're not menopausal yet. And they don't want to offer even thinking about HRT until they know you've already gone through menopause. And by then we know it's kind of too late. It's not too late to start HRT, but your benefits are much better if you start when your symptoms start.
Susan asked, do you recommend a low dosage of testosterone for women who have low testosterone?
Well, we don't specifically prescribe testosterone. Testosterone is a controlled substance. It's used by a lot of people in the weightlifting and bodybuilding industry. It's used by athletes. So it's a controlled substance, because taking too much testosterone can actually be harmful to both men and women. So instead of using testosterone, we typically prescribe DHEA, which is I always mispronounce this, dihydroepiandrosterone.
Wow.
We use the acronyms more. But,
I don't even try.
You don't even try. But anyway, this hormone, DHEA, is one that when you ingest that, your body breaks it down into both estrogen and testosterone. So it's a gentler way to give you some testosterone repletion without actually prescribing a controlled substance. So we usually keep that at low enough doses that it's safe and that you won't get side effects from testosterone.
But yeah, it can be very beneficial. And it is, it's something that I think until recently people didn't recognize as much, that women need that. Testosterone was always, that's the thing these big giant guys in the gym take. And women were afraid to die. I don't want to be giant like that. And we're not talking about these giant doses. And that's the nice thing about DHEA is, in the dosage that we prescribe, it's not going to do that for you. But it is a hormone that's produced in the ovary, and your testosterone levels on average are at least 50% down between when you're 50 versus when you were 20, and that's can make a big difference in how you feel. And so generally giving a little bit back with DHEA for a lot of people is that sort of extra thing that really makes them feel better.
I've heard both a cognitive therapist and other non-OB-GYN MDs advocate for bioidentical HRT in perimenopause to protect the brain. Is there any opinion on that?
Yeah, so estrogen specifically is very beneficial to many tissues throughout the body. Skin, hair, vagina, especially the mucosa there. But we've seen some studies, and there's data to show that that estrogen protects the brain and helps keep the brain healthy. All those connections and neurons, and so there's some thought that and research that it can prevent your cognitive decline and development of dementia. So HRT is beneficial in that way too. So it does help to protect the brain. So I would agree with that.
It also helps with the brain fog, which is a very common symptom of menopause or the menopause transition. And so beyond the sort of long-term effects that you don't really necessarily feel, there are some immediate effects as well that help with brain fog and help you with your thinking, and can be really important, especially if you're on the job and all of a sudden you're like not thinking real clearly. That's a big handicap, and it can help with that.
I think in the past, a lot of doctors were using HRT to help prevent Alzheimer's disease as well, especially before we had all the Alzheimer's medications that came out as well.
Yeah, the general rule of thumb, HRT does help for a lot of preventative stuff. In general, I think the thinking is that, HRT, if you have these symptoms, is definitely worth taking. And as a benefit, you get all these other benefits as well. If you have, say, osteoporosis, HRT will help with that. But if you specifically need treatment for osteoporosis, there may be better drugs for that specific problem. And the same thing with brain health. It definitely can help that. But if you've got a problem already, and you don't have the perimenopause symptoms or the menopause transition symptoms, there may be better medicines. And so that's where this controversy, I think, comes from. But it definitely helps. And it's one of the sort of side benefits you get from the hormone replacement therapy.
Ivory said, my sleep is iffy. ZzzQuil was my go-to before Winona. Is that still okay, or are there other or better sleep aids you'd suggest?
Well, we'd hope that, as you start your HRT, that your sleep will improve, because that's one of the symptoms of menopause that a lot of women suffer from. Sometimes it's the only thing that people start to notice as they're making the transition. So it's perfectly safe to continue taking the ZzzQuil when you're first starting, but we would hope that you maybe would need it less and less as you progress into your treatment.
Sarma said, how do you determine the individual dosages and proportions of hormones for a person? I believe we answered this one.
Mm-hmm.
Okay. Jamie said, is HRT therapy permitted with Lexapro?
Yes. So there's no contraindications to taking HRT with Lexapro or any of the other antidepressants or what we call SSRIs. So that would be perfectly safe. So again, when you on board with Winona and you do your medical history questionnaire for us, there's a section that will want you to list all your medications. And in that, we want you to list all your prescription medications, any supplements, any over-the-counter things you're taking, things you're purchasing, vitamins. We really want you to be as comprehensive as possible, because that allows us as your doc to really make sure that we look for all those interactions that are possible, and let you know what we think you should stop, if the other medications you're taking are safe. So make sure you disclose all of that for us.
There's something out there on the internet, I might be on the Mayo site, I'm not sure, that talks about DHEA and SSRIs and the danger of serotonin storm. And you've got to be on massive doses of DHEA for that really to be a problem. So, we don't really prescribe over 50 milligrams a day of DHEA, and it's not going to cause a problem or interact. But just in case you see that out there, the problem with DHEA is there's these people in the gym that are taking 200 milligrams or more a day. And at those doses, there's some issues that can happen. But those issues aren't going to happen at 25 to 50 milligrams. So some of the stuff you read about DHEA can be pretty scary. because you have these people taking mega doses of it. And with mega doses, yes, it can cause problems. But in the dose that we prescribe, those aren't issues.
Lily said, how can I get a consultation with a doctor before I order the HRT meds? I'm not sure what is good for me. I know I prefer pills. I'm 59.
So when you on board, after you fill out your medical questionnaire and give us all that information, I think you'll get a suggestion for what medication might work for you. And what you'll do is you'll immediately message your provider and you'll say, I'd really like to talk about things before we prescribe anything. And that will prompt us to start our conversation with you about, your specific situation before we order meds.
Yeah, there's actually 3 places where that can be done. So on the screen on the onboarding, where it shows you medications, there's a button that you can hit that says that you'd like to talk to the doctor before prescribing. And that sends us a message so that we know that. There's also a place where it says, is there anything else you'd like your doctor to know? You can type a message in there that says, please don't prescribe until we have a chance to discuss this. And then the third option, if you get past that and you forgot to do that, the third option is to go into the patient portal and send us a message saying, please don't prescribe. Because generally with the onboarding, if you say, hey, yeah, this sounds good to me and I want this, then that goes to us. And if we think you're a good candidate, we'll prescribe it unless we see one of those messages. So there are 3 different, we were just talking, patient services, and I was just talking about this. There's 3 different ways for you to get our attention, to let us know that's your preference.
And Lily, I linked to the onboarding in the chat. Chris said, if bioidentical hormones are commenced in perimenopause, are they to be continued until menopause only, or to continue indefinitely post-menopause?
I think we talked about this a little bit when we were answering the question, like, how long do you stay on it? So, really, the HRT can help you during that most difficult time where you're really suffering from a lot of symptoms. And then we can start having that discussion of when you want to stop it. You don't want to stop HRT abruptly once you've completed menopause, because at that point, your body still has estrogen kind of weaning out of those ovaries. They might still try to do their own thing, but you might still be suffering from hot flashes and night sweats. And sometimes if you stop your HRT too soon, you can get a horrible resurgence of symptoms. And that sometimes those rebound symptoms can be worse than your original ones. And so, we'll have that conversation and come to a mutual agreement on when to kind of wean you off the medication, but you don't have to do it so abruptly.
Sarma asked, what are the possible side effects with HRT if taking thyroid medicine for hypothyroidism?
Well, so, your other medications you're taking, as long as your thyroid is well controlled and as long as your thyroid medication is well dosed and you don't have any issues with that, starting HRT really shouldn't affect your thyroid too much. But what we typically notice is that, patients talk about getting bloating, some water retention when they first start hormones. Some women will also notice breast tenderness is pretty common because the breast tissue is responding to the estrogen. And then we also mentioned earlier in this presentation too is about the abnormal bleeding too. So sometimes when you're first starting hormones, you can have some spotting and some irregular bleeding in the beginning. Those are the most common things that I see. There's some other symptoms that can occur, but they're more rare and we don't see them with a lot of frequency. I don't know if you want to add to that, Dr. Green.
So just the thyroid. So there's a couple things. Thyroid replacement can be tricky, and thyroid Synthroid or levothyroxine or whichever thyroid hormone that you're using to replace, they're finicky drugs, and the dosage of those tends not to be so stable. And so I would imagine that the doctor that's prescribing those is going to be checking thyroid levels and TSH levels. Thyroid is different than HRT. Thyroid is something that you want to follow blood levels with. So there are some drugs that you need to, some you don't. HRT we don't, but thyroid is one of those ones that you do. And so thyroid hormones can change for who knows whatever reason thyroid replacement needs. There's nothing specific about hormone replacement therapy that necessarily will change your thyroid hormone replacement needs. But those are, like I said, finicky and sometimes change anyway. And so, that's something that you want to follow your doctor's advice that's prescribing that. And they're probably at first maybe wanting to check it every 6 weeks or 3 months, and eventually every 6 months. But usually once you're stable, every 6 months to a year, they want to check that and potentially adjust it. But again, that's irrespective really of being on hormone replacement therapy. If you dig deep into this, and unfortunately with the internet, it's not that hard to do. There's something called sex hormone binding globulin, which can bind up the thyroid that's circulating, so that your free thyroid hormone that's actually available to work can go down if that protein goes up. And in some circumstances, I guess it's theoretically possible for hormone replacement therapy to increase that protein, that sex hormone binding globulin, which can change the thyroid needs. But that's pretty unlikely, honestly. It's more of a theoretical than anything else. But just to be complete, because you might see that out there on the internet with people trying to act smart like I'm doing right now. But the bottom line is there isn't really anything about hormone replacement therapy that should change the thyroid dose. But the thyroid dose can change on its own anyway. So it's something that needs to be followed.
Just as a note, we have a lot more questions. And so if there's any ones that are being repeated, I'm going to skip over those, but we're going to send you guys a replay afterwards. So if you missed it. The next question is from Mel. When is the best time to take DHEA?
So we talked about this a little earlier because we had a patient talking about staying more alert and awake, taking it in the evening, and we talked about switching to the morning. But really the answer for you, Mel, is when it fits into your daily lifestyle the best, and see how you feel. So, a lot of women choose to take it in the morning and they feel great doing that. But if it's easier for you in your daily schedule to take it in the evening, that's okay too.
Next question is Colleen. Does one hormone treatment over another cause more irritability? Currently on the combo cream and a noticeable increase in irritability.
I haven't found that one mode causes more irritability than the other that you can predict. I have had patients have issues on, say, pills. We switch them to cream and they do better, and vice versa. And so sometimes everybody's a little bit different. But I don't think there's at least I haven't seen any data for that, and I certainly haven't noticed that there's a common thread that way. If you're on DHEA, that sometimes can cause irritability as a side effect, I think more often than the cream. Dr. Brown, do you have you noticed any trends that way?
No, and I would just add that sometimes some patients just tend to be a little bit more sensitive to the hormones than others. But I agree, switching from one modality to the next seems to sometimes help that. So the DHEA, I think for some patients, they respond to that a little bit more than the estrogen and progesterone.
Teresa asked, is it okay to take oral estradiol plus the estradiol patch? My other doctors seem to think it's too much and that the oral estradiol might cause blood clotting, but I feel really great with both. There's a lot of breast tenderness. Is this okay long term?
So the increase in breast tenderness might be telling you that it's too much estrogen for your system. I don't know why you would be on both the patch and the pill, because we could dial up your dose of the patch, or we could put you on a higher dose of the pill rather than you having to take both modalities. I think, the only other thing I would say is that I'd want to make sure that, the doctors that are prescribing those, it's coming from the same source, because normally gynecologists won't prescribe both of those. So are you getting one from one doctor and the other from someone else? But yeah, I would worry that it might be too much estrogen.
The other thing, in theory, pills have a higher risk of blood clotting of DVT and PE than
the transdermal,
the transdermal. However, it's kind of like telling you that you're twice as likely to win the lottery tonight. You still probably shouldn't go out and buy a lottery ticket. So an increased risk of a rare event is still a rare event. And so, yes, technically there's a decreased risk of blood clots like DVT or PE on the oral estrogen, but it's still a really rare event. And honestly, if you have a history of clotting problems, a history of DVT or PE, you probably shouldn't be on either one.
Next question is, I'm currently on a topical HRT of E2, E3, T progesterone. Would this be something that could be done with you after review of my prior records and labs?
You want me to get that?
Sure, because we don't have topical tea.
So the answer is no. However, it's a no with an asterisk. For most patients, and I have patients come with very complicated hormone regimens from other places, and for one reason or another want to switch, or they like the convenience or the cost of Winona. And I found that I switched them to a nice, simple approach, and it works fine. I've talked about this before. It's sort of the personal trainer thing. I've noticed in my gym, well, in every gym, if any of I have some of the personal trainers in my gym are friends of mine, but they tend to put people on these really complicated exercise regimens with 15 different exercises, and when really 4 or 5 can do. And I think part of it is that it makes you reliant on the personal trainer. And I think some of these people that do these creams are doing the same thing. They mix these really complicated creams that make you really reliant on them. And more complicated isn't necessarily better. For most people, a nice, simple, estrogen progesterone mix with some DHEA if you need some testosterone tends to do the job. And so I've always been of the belief that simpler is usually better. And so we're happy to take over your care and put you on a regimen that should work for you. It won't be exactly the same, but I think you'll be happy with the results.
Beth is interested in the creams. She's asking, are all your products naturally sourced, not synthetic?
Did you want to grab that one, Dr. Green?
Okay.
The stare.
Yeah. So all of our hormones are bioidentical. They're yam-based hormones. Hormones, you don't squeeze a yam and get hormone out of it. So there is some processing that has to be done to turn the ingredients from the yam into the bioidentical hormones. So everyone has sort of a different idea of what natural is. These hormones are the exact same hormones that your ovaries produce. And so your body can't tell the difference. And so these are the natural hormones, as opposed to, for instance, Premarin, which stands for pregnant mare urine. And it's basically estrogen. They have these farms of these pregnant horses, and they collect their urine, and out of that, they get hormone out of them. Now that's natural hormone as well, but it's not bioidentical hormones. So there's a lot of hormones in there that are unique to horses that the normal human body doesn't make. It doesn't mean it doesn't work, but I think it has more side effects. The bioidentical hormones are exactly what your ovary makes, and that's what we use. So we use, and then there's synthetic hormones that aren't in any mammal, aren't in any, that are made in a lab that sort of work. They're close. Estradiol, estradiol is an example. That's the estrogen that's in birth control pills. That's not really found in nature. It works, but it's not exactly the same as what your body's used to. So the hormones at Winona are bioidentical. They're yam derived, and they're exactly the same as what your body makes. Hope that helps.
Michelle said, what are the financial benefits of ordering Winona versus seeing a doctor in person?
Well, really the financial benefits are that you're not having to go see your physician in person, meaning the transportation to get there, the copay, and all of that involved. But really Winona exists for patients who do not have a doctor who's really willing to prescribe them HRT. So if you have a physician that's willing to, that's great. But we're here for those patients that don't have that venue. So that's really the difference. You're not paying for an office visit with us when you see a doctor through Winona and you're getting HRT with us. You're just paying for the medication. So that's the big difference.
Plus, I think Einstein is the one that proved that time is money. Kidding about the Einstein thing, but you can make an appointment with your doctor. A month or so from now, they'll get you in, and you'll sit in the waiting room for half an hour to an hour, and then you'll sit in the little room, and then your doctor will see you and may or may not prescribe the medicine, and then you'll have to go over to the pharmacy and wait in line there, and then if you go to Rite Aid like I do, you get the ice cream cone on your way out, which is necessarily good for you. But I mean, so there's a whole time commitment of seeing your doctor and going to the pharmacy that you don't, and there's a little unknown as to whether they're going to write it or not. But there are advantages and disadvantages of your personal physician that you can see locally. They can do things that we can't do. So that's something that you need to balance. So yes, definitely, if you don't have someone that's willing to write this for you, you've got us, we've got your back. Or maybe you like the convenience of being able to do this from your home, and being able to message us, whenever you have a question, and we get back to you pretty quickly. So there are, financial advantages, but there's also, more importantly, maybe personal advantages as far as time management.
The next question is, what is the average cost of the product if I chose the subscription option, and is there a time length obligation?
So it looks like a patient below answered that for Beth.
Oh, thank you, Melissa.
Thank you, Melissa Jones. She posted her personal, what she pays for her supply. So that's really helpful.
If you need estrogen and progesterone, the cream is going to be the most affordable option. It's $79 for a month and $199 for 3 months. And the DHEA is $24 for 3 months. The pills are a little bit more in combination, about $15 more. If you've had a hysterectomy and you don't need progesterone, then the pills are going to be a little less expensive than the cream as far as cost goes. The patches are much more expensive than either choice. So as far as cost goes, the cream is really, for most people, the best option from a cost point of view. There's no, quote, obligation. I recommend giving it a 3-month trial because that's how long it really takes to know whether it's going to work for you or not. But you can cancel anytime, and we'll stop sending you medications. We just ask that you do that before the medications go out. Once they leave the pharmacy, it's not like, look, you don't want us to give you medicines that were in someone else's house and they mailed back to us. So once they leave the pharmacy, we can't accept returns for obvious reasons, as they are medications. But if you decide that this isn't the right thing for you, so you just send us a message, or you go on the portal and cancel it. I can tell you, so it's probably more of a story than you need, but EA Games, I will never buy one of their games or let my kids subscribe to one of their games because they're impossible to cancel from. I had to threaten to get out of some monthly EA games my kid got into, and I would never do that to our patients. That's something that I feel very strongly about. We don't play that game where we make it really hard to figure out how to cancel. If you're not happy with it, then I'm sorry this didn't work out for you, and of course, let us know and we'll stop the subscriptions from coming.
The next question is from Shelly. I am on DHEA and cream. My face exploded with acne, so I stopped taking DHEA. Is that okay? Will my results still be good?
Yeah, that's absolutely okay. That's what I would have recommended. Acne is one of those side effects that we do see sometimes with DHEA. Not every patient will experience that, but when I do have patients that get, acne that's bothersome on the DHEA and it's not getting better, then we usually try you off of it for a little while. You'll still get good results with the rest of your HRT. And generally after your skin clears up, sometimes we can kind of discuss whether or not to start the DHEA back in again. Sometimes patients tolerate it on a second try and they don't have the acne quite as bad.
Tara said, I just want to say I'm very impressed with the responsiveness of my Winona doctor. I started the hormones, but had a few questions, and my Winona provider provided answers or recommendations within 24 hours, which is much better than I could get in one office visit or follow-up call with my gyno. Or OB-GYN, sorry.
I've been scolded by patients for responding too quickly. In fact, I've been,
well, I think he's a bot.
Yeah, I've been accused of being a bot. I was sitting in the office one day and I had a bunch of cancellations. And so I was doing my Winona and someone's like, you must be a bot because why would you be answering me so quickly? I'm like, well, I had some cancellations. I'm like, oh, sorry. We do our best to get back to you as quickly as we can. Not all of us act like bots, but we do try to be responsive because we know it's important to you when you have an issue that you get an answer back.
Krista asked, what is the best diet to follow during the transition?
Well, so there's a lot of people online. If you Google menopause diet, you probably get 20 different opinions out there on the internet from different experts. But really, you want to just have a well-balanced diet. You want to make sure that you eat whole foods, meaning that you're eating not processed, highly processed foods. You want to eat lots of vegetables and fruits. Make sure you're getting all the nutrients that you need in addition to protein, and that balance of nutrients. I usually tell my patients, I want you to shop in the periphery of the grocery store. Stay away from all the aisles. If it's shelf stable for 5 years or more, it's going to be in your body for 5 years or more. So, the things that, go bad more easily, the fruits and vegetables, the things that spoil more quickly are the healthiest things to eat for you. Another thing I think it's really important to get plenty of when you're going through the menopausal transition is fiber. The American diet does not have enough fiber in it at all. And so, most of it should come from, whole grains and green leafy vegetables. So really focusing on, eating good foods to fuel your body, eating with intention, taking your time when you eat, and really, being selective about what you put in your body, trying to avoid things like, fried foods, fast foods, all those things, sweets, candies, things like that. They can cause more harm than good, and can really give you a hard time when you're trying to trim down and trying to maintain a healthy weight and deal with all these other symptoms. The other thing too is that if you're experiencing a lot of hot flashes and night sweats, you want to avoid drinking a lot of alcohol. We usually find that women that have hot flashes, their hot flashes intensity and frequency go up the more that they consume. And that's unfortunate because, wine is a great thing sometimes. So, that's another thing to consider too. But in general, well-balanced diet, healthy whole foods, lots of veggies and fruits, added to those things would be good.
I would say that the diet that you can stay on is the best diet. So this is something that you want to really don't think of as a diet, but think of as a lifestyle change. So
like your eating plan. Yeah.
You want to make changes you can sustain. Most of the fad diets, unless you're trying to get into a dress for, a wedding or something, you can lose a whole bunch of weight in a month, but you're not gonna be able to keep that off. And so you really want to find something that you can sustain, and that doesn't feel like punishment, but something that is, okay for you. That's going to be different for everybody.
Tammy said, I've noticed I've lost more hair than normal since I started DHEA and HRT 1 month ago. Will this continue?
It should not. This should be a temporary phenomenon. And we see this in women, that go through pregnancy and postpartum. We see it sometimes in starting HRT or women going through menopause. But whenever you have a sudden change in your hormonal environment in your body, your hair follicles are typically on all different schedules. And then when you have a change in your hormones, they sometimes will all go on the same schedule. And there's a scientific term for this called telogen effluvium, something we had to memorize back in medical school. But we see this pretty commonly. And I used to see this in a lot of patients in the office that would come back after having babies, that they'd come back with their brush, handfuls of hair falling out. And it's not that they're suddenly going bald. It's just that hormonal reset of all those hair follicles causes that. And it's temporary. Generally staying on the HRT, especially the estrogen, will help to strengthen the hair follicle. And generally your skin and hair will be healthier with long-term use.
Susan asked, on what basis do you prescribe testosterone?
Quick answer to that is we don't.
Right.
we mentioned that earlier.
Yeah, we use DHEA, which gets broken down into estrogen and testosterone, but we use it at a dose that's not going to be pushing testosterone levels to make you a monster in the gym, or turn you, give you those testosterone side effects that people worry about.
Jonathan, I don't know if your questions are just if you're a fan of Kathleen, but is there any medication for shiny hair for menopause or?
I don't know, but a man asking about menopause stuff is a little suspicious.
Yeah. So Tara said, I've noticed much improvement in my fingernails since starting with the ice cream and DHEA. That's awesome. We're going to take this last question from Danielle. What are the alternatives if a patient can't tolerate DHEA?
Well, if you really can't tolerate the DHEA, you don't have to take it. You could just do estrogen or if estrogen, progesterone, or the estrogen alone if you've had a hysterectomy. So you don't have to take the DHEA. And sometimes it doesn't work for every patient. I kind of tell patients when we're trying to find the right medication, the right dose, it's kind of like women trying to find clothes or that pair of jeans, right? You can never find two women that like the exact same cut, the exact same style. And it's really trial and error. And we really see, what your body tolerates and what it doesn't. And if the DHEA just doesn't work for you, then we don't need to use that.
Well, that is it for our questions. So thank you everyone for attending. Any closing thoughts, Dr. Green and Dr. Kat?
No, thanks for coming on tonight and asking us questions.
Yeah, we appreciate you guys. And Dr. Brown, I really appreciate you. She was our first Winona doctor besides me. It's really a great addition to Winona. I really appreciate everything you do.
It's nice to interact with our patients like this, besides just on the portal. So that's nice.
Well, thank you everyone. And if you have more questions, we have this webinar every month. So go ahead and sign up.
And let me plug the Facebook group. The other thing is, don't be afraid to message us in the portal. So that's the other thing. Right. We're very happy to answer.
That's what we're there for. Yeah.
And we have a very active Facebook group that you can join. And there's a lot of support among each other that I think is really worthwhile. The caveat is, don't believe everything you read on social media either. But it is nice to have the support. And we have a huge number of patients there.
In the Facebook group?
Yeah.
Yeah, let me send everyone the link.
But it's a really good community. So I would encourage you to go there as well.
Oh, and Samantha's asking, where is the portal? When we talk about the portal, we talk about, that's the messaging area in your Winona account. So that's where you message your doctor. That's what we're referring to when we say the portal.
Here is the group. We have 3,700 people, so
not bad.
Quickly.
There's a few people going through what you're going through, and it's nice to chat together and share different ideas.
Okay. Well, thank you everyone, and we'll see you at the next webinar.
All right, take care.
Bye.